Hi everyone. So our next topic is divisions of the available bone. I do realize that these topics are quite dry. You might not find them that interesting, and I totally agree with it. But let me tell you that these topics will help you explain your patient that why a certain implant failed within a span of 1 year, or why one particular implant lasted for years. Although there are so many factors that decides how long the implants would survive, one of them is the morphology of the bone. So divisions of the available bone we have classified into A, B, C, and D. B and C have subclassifications. So we'll discuss about each of them in detail and see how a particular division of bone impacts your treatment plan. So let's start with division A bone. Division A bone is the abundant bone, the most ideal bone. मतलब ये बोन अगर आपको मिलता तो मतलब you should be like okay, everything should go favorable, and the implants that I'm going to place should definitely last long. So what are the characteristics of division A bone? So when you place an implant, see, when we talk about the division of bone, it is dependent on the implant that we are placing. So for example, we are placing an implant of 4 millimeter diameter and 10 millimeter length. So for that, if we have 1.5 millimeter bone facially and 1 millimeter of bone palatally or lingually, then that particular classification of bone can be considered as division A bone. So division A bone is formed soon after the extraction. The bone is sufficient in both height and width. Dimensions of division A bone, you have width of more than 7 millimeter. Again, the diameter of implants govern it. The height is usually more than 10 millimeter. Mesiodistal length is more than 7 millimeter. Angulation of occlusal load, that is between the occlusal plane and the implant body, is less than 25 degrees. Crown height space less than 15 millimeter. And what type of prosthesis can we give? We can give FP1, FP2, FP3, RP4, or RP5. So in most cases, we will be giving an FP1 or FP2 prosthesis. But if it is maxillary anterior, for example, where aesthetics are of primary concern, then we might consider giving an FP3 prosthesis. Removable, in my opinion, it is more dependent on the budget of the patient, and especially when you are doing full arch cases, when the patient doesn't want to spend a lot on fixed prosthesis, and the crown height space is less for a removable prosthesis. So you do an osteoplasty and give this RP4 or RP5 prosthesis. All right, next we move to division B, barely sufficient bone. So, division B bone is basically a division A bone with compromised width. So, we all know that the bone resorption starts at the expense of the facial cortical plates, because the cortical bone is usually thicker on the lingual aspect of the alveolar bone. So bone resorption starts taking place, the bone starts losing its width, and it makes the bone less suitable for placement of an endosteal implant. Okay, division B bone dimensions. So it has been further classified into B plus and B minus width. In B plus, you have bone of 4 millimeter to 7 millimeter, and B minus, you have 2.5 to 4 millimeter of bone in width. The height it is similar as that of division A bone. Only the difference is difference in width. Suppose you have a 7 millimeter of bone that makes the bone ideal for implant placement in most of the cases. Obviously, when you're placing a 6 millimeter diameter implant, 7 millimeter might seem less. But in most cases, 7 millimeter of bone, if you have, it is essentially a division A bone. B minus width, you have 2.5 to 4 millimeter. Suppose you have 2.5 millimeter. In such cases, you need to think and plan, okay, what can be done. So either you can convert the bone into type A by doing osteoplasty, you can place narrow implants, or you do ridge augmentation. So, in this paragraph, mostly these topics are there for patient education. So, if you go through it once, you will be able to convince your patient to take the implant treatment as early as possible, because the bone resorption pattern, uh, it is different in different regions, and as clinician you should be aware that which regions you cannot afford to wait for long. So go through it once, it will help you explain your patient about implant treatment. Okay, so when you have division B bone, there are three different treatment approaches to convert into a type A bone. The first thing is definitely the osteoplasty. You reduce the bone, and while you reduce the bone, you gain some width. Okay. Another option is you go ahead with narrow implants. Third option is ridge augmentation. So basically, you graft the site with some bone graft material. So let's discuss the advantages and disadvantages of each of them. So when you're doing an osteoplasty, basically you are shaving off some bone, and in my opinion, it should be reserved for those cases when you're doing a full arch. Suppose you're doing a full arch, you can do an osteoplasty and convert into type A bone. But if you're placing a single implant, osteoplasty might not be the best treatment option for this type of bone. So in such cases, you should consider about delivering a narrow implant or doing some ridge augmentation. Another disadvantage with osteoplasty is you increase the crown height space, and when the crown height space is increased and you're giving a fixed prosthesis, the unfavorable forces, they tend to increase. All right, second is narrow available bone. You use a smaller diameter implant, but as you all know that not in every case you can use a narrow diameter implant. For example, you are restoring a posterior first molar. In that case, the narrow implant is definitely not the right option. But if you talk about mandibular anterior region, definitely you can go ahead and place narrow implants. All right. Okay, let's see the disadvantages of narrow implants. So almost twice the stress is concentrated at the top crystal region around the implant. Less overall surface area means that lateral loads on the implant result in almost 3 times greater stress than division A root forms. Fatigue fractures, the crown emergence profile is less aesthetic, the maintenance and hygiene it is compromised, the implant design is often poor in the crestal region. The angle of the load must be reduced to less than 20 degrees to compensate for the smaller diameter. And in most cases, you would need two implants to restore a molar. So, this again increases the overall cost for you and as well as the patient. because we all know that narrow implants are not cheaper than the wider implants. They all cost the same. So if you are using more number of implants, the cost definitely goes higher. Third option is grafting, and in my opinion, this is the best treatment option in most of the cases. So you can either use a GBR or use block grafting technique. Okay, so uh, looking at this paragraph, so this is the importance of reading from textbook. You develop this decision making abilities. So when you see a division B bone, you know that what type of treatment approach should I use. Should I go for a block graft, or should I use GBR technique? So see how beautifully it is given. Bone augmentation is most predictable when the volume to augmentation is minimal and is for width, and least predictable when height is desired. For example, usually a width increase of 1 to 3 millimeter may be obtained with an allograft and a guided bone regeneration, whereas greater than 3 millimeter of width is more predictable with an autologous block graft. So now you won't be scratching your head when you see such cases, because you have already read, okay, the augmentation that I need is more than 3 millimeters, so I'll go with the block graft. So what most of the clinician they do is they start scratching their head. They'll call their seniors, and trust me, उनको भी कुछ खास पता वैसा होता नहीं है. So it wouldn't be of any help. So the best way to learn is to start reading books, and trust me, it covers the silliest doubts that you can ever imagine. Once I started reading books, I realized that okay, everything, every small details are covered. And this contemporary implant dentistry fourth edition, it is really amazing. The book contains all your silly doubts. So next we are moving to bone spreading. Okay, so now you are. This is also a type of an augmentative procedure, but instead of layering your bone with some graft, what you are doing is spreading the bone. You are increasing the width of the bone using bone spreaders. So this is an advanced topic which we will discuss when we are discussing about regenerative procedures. All right, so next we move to division C bone. So how division C bone is different from division B bone. So far we have seen that if you use a narrow implant, the type B bone can become a type A bone for that particular implant. But in division C type of bone, the bone morphology is in such a way that any type of implant will be unfavorable. So division C is further classified into division C minus W, division C minus H. C minus W is loss of width, C minus H is loss of height. Okay, so division C ridge is deficient in one or more dimensions: width, length, height, or angulation, regardless of the position of the implant body into the edentulous side. That's what I spoke. The resorption pattern occurs first in the width and then in the height. As a result, division B ridge continues to resorb in width, although height of the bone is still present, until it becomes inadequate for any design of endosteal implant to accommodate. This bone category is called division C minus width. The resorption process continues and the available bone is then reduced to C minus H. So you see the sequence: division B bone transitions into division C minus width, and that again transitions into C minus height. Let's see the dimensions of the division C bone. Width is 0 to 2.5 millimeter. Height CH bone. Angulation more than 30 degrees. Crown height space more than 15 mm. Prosthesis most likely FP2 or FP3. Removable RP5 because of increased crown height space. Okay, so this is an important paragraph. The doctor must appreciate that the C width bone will resorb to C H ridge as fast as the A resorbs to B and faster than B resorbs to C width. In addition, without implant or bone graft intervention, CH available bone will eventually evolve into division D. So this is important when you are consulting your patient. You can tell them that this is going to be the sequence of resorption. If you don't take the treatment now, further we might have to do extensive grafting, which would increase the cost of the treatment. So in that way, you will be able to convince your patient to take the treatment. So what are the treatment options for division C bone? Definitely, we are not going to use a narrow implant. You have to do certain augmentation procedures. All right. So what you can do is either you can do an osteoplasty, which is not an augmentation, but you can do an osteoplasty and convert into type B and then place narrow implants, or you can do an osteoplasty, convert into type B, and then you can use minimal grafting. You can use block graft. What all we can use when we have the height is less, you can go for subperiosteal. In maxilla, there are options like remote anchorage, example zygomatic implants. So when it comes to division C bone, you have multiple options, but they do require some sort of surgical and prosthetic skills. And in most cases, the clinicians are not so comfortable with the augmentation procedures. Okay, there's something called disc implants. It is not being used now, but you can have this options as well. Okay, so we see the treatment option: osteoplasty, root form implant, CH, augmentation procedures before implant insertion, subperiosteal, and disc implants. Okay, now we have something called root form implant, CH. So when this option is viable, you can place an implant in division C bone even without augmentation, but there are certain conditions where you can do this. For example, anterior mandible. Usually, you will have a type C H bone where the bone has reduced height and width. So, but you can still place an implant because I'll show you with this diagram. See, this is the CH type. So here you can see if there is no anatomical barrier over here, you can easily place an implant because in most cases CH type you will have sufficient bone width. However, with this approach you can only deliver an RP4 or RP5 prosthesis because the crown height space is significantly more. So, in such scenarios, the implant placement is not an issue. You can definitely place an implant, but the prosthesis that you have to deliver would be a removable one. Fixed prosthesis, it would be a disaster. All right, then we move to division D bone. So, long term bone resorption may result in complete loss of the residual ridge accompanied by basal bone atrophy. So, in division D bone, you can expect some basal bone atrophy as well. So, now we'll see division B, D bone is a type of bone where you definitely need some sort of augmentation procedure before you even think of placing implants. And in most cases, you go ahead with, in mandible, you go ahead with subperiosteal TL implants. I am not sure about basal implants, but you can just read about it, or you can go ahead with in maxilla. You can use zygomatic implants and other remote anchorage implants anchoring the nasal bone. So, in division D bone, you cannot place a root form and ostial implants. Even in the anterior mandible region, you need augmentation procedure or you need to use a different type of implant as such. The prosthetic result for division D without augmentation is the poorest treatment outcome for all divisions of bone. Fixed restorations are nearly always contraindicated because of the CHS is so significant. See, this is what, if you are new to implantology, it is not just about placement of the implant, it is more about the restoration. So, and how long the restoration would last. So, implant failures happen mostly because of mechanical reasons, mechanical or biological reasons. And mostly you would see all the failures happening once you have loaded the implant, because you have used the wrong processes or wrong type of implant. In a particular case, the implant's survival rate, it reduces significantly. So the completely edentulous division D patient is the most difficult to treat in implant dentistry. Benefits must be carefully weighed against the risk and complication. Although practitioner and patient often regard this condition as the most desperate, these patients do not usually understand the possible complication that may result. Oroantral fistulae, deviated facial, then you can have neuropathy. There are so many complications that can happen. Even at times, you can expect fractures in the mandible. So, when we talk about grafting in a division D bone, the iliac crest bone grafts are the gold standard. All right, okay. There's something I have missed over here. See, when we talk about division D in posterior maxilla, you have an option of doing a sinus lift, or division D or division C. You have an option of doing a sinus lift. This part I missed out. So, even a sinus elevation and placement of root form implants is an option in case of posterior maxilla. But again, with severely reduced or atrophied maxilla, even the predictability of sinus elevation reduces. Okay, so there's one scenario when you can place endosteal root form implants without autogenous graft. When the remaining bone is dense and the opposing arch is edentulous. Care must be taken during placement because mandibular fracture at insertion during post-operative healing is possible complication. So implant failure results with circumferential bone loss, which may be associated with mandibular fracture through the implant site. An RP5 removable restoration is usually indicated for division D with only anterior implants. However, RP5 restoration allows for continued resorption and atrophy to continue in posterior regions. Therefore, the prudent therapy is to educate the patient as to the risk of his current condition and other autologous bone graft and implants to support an RP4 restoration. All right. So, but in of the cases of division D in mandible, what we do is we place two implants in the mandibular anterior region and then give an overdenture, which is RP5 prosthesis. So that's all for today's lecture. In the next lecture, we will be talking about immediate implant, all those surgical protocols, the indications, contraindication. The topic will be taken by my colleague, Dr. Akriti. Thank you.